Good afternoon, everyone. I'm Diane Hoffman, and I'm on the faculty and direct the Law and Healthcare program here at the University of Maryland Carey School of Law. It's my pleasure to welcome all of you here today for the third of our Rothenberg Healthcare Law and Policy Speaker Series for the 2021-22 academic year. The series was established with funding from the Karen Rothenberg and Jeffrey Seltzer Law and Healthcare Program Endowment. Professor Rothenberg was a former dean of the law school and founder and director for many years
that's the way I feel about
our law and healthcare program.
I mean,
The series
waiver case that I had with Stacy.
Oops. Could everyone please mute? Thank you. As I was saying, the series focuses on contemporary issues in healthcare law and policy. And because of its virtual format, we are able to bring leading health law and policy experts, scholars, and practitioners together with attendees, which in past presentations has included people from around the world. And what we hope will happen here is an informative presentation and a vibrant interchange between the speaker and the participants. Our first speaker this year was Dr. Eric Greene, the director of NIH's National Human Genome Research Institute, who spoke about the challenges and opportunities associated with genomics research. And then our second speaker last fall was Professor Lisa Ikemoto, who was Martin Luther King Jr. professor at the University of California, Davis School of Law. She spoke about the reproduction of genetic race. So our theme last fall was genetics. And this spring, our theme is health disparities. Not only do we have Dean Dayna Matthew speaking with us today, about Just Health, a medical legal partnership to help health structural racism. But on March 31st, we will hear from Ruth Faden, who's the founder and faculty of the Berman Bioethics Institute at Johns Hopkins, who will be speaking on structural injustice. To introduce today's speaker and moderate the Q&A, I'm going to turn the Zoom host function over to Professor Sarah Gold, who directs the Medical Legal Partnership here at the School of Law. Sarah?
Thank you, Diane, and welcome everyone. It is really a privilege to introduce our speaker, Dr. Dayna Bowen Matthew, Dean of the George Washington University Law School. A nationally recognized lawyer and legal scholar with 3 decades of industry and academic experience, Dean Matthew is the first woman to lead GW Law. An expert in health equity and public health policy with a passion for public service, Dean Matthew joined GW in 2020. She previously served on the faculty of the University of Virginia School of Law as the William L. Matheson and Robert M. Morgenthau Distinguished Professor of Law and the F. Palmer Weber Research Professor of Civil Liberties and Human Rights. There, she co-founded and directed the UVA Equity Center, an interdisciplinary research institute dedicated to building relationships between the university and its surrounding community to redress racial and socioeconomic inequality. Prior to her tenure at UVA, she served as professor of law, vice dean, and associate dean of academic affairs at the University of Colorado Law School, where she co-founded and directed the Colorado Health Equity Project, an incubator for medical legal partnerships that removed legal barriers to good health for underrepresented patients. Dean Matthew is now working with scholars across the George Washington University to establish the Equity Institute Initiative at GW with the mission of creating a university-wide research institute to support research and pedagogy that advances racial, ethnic, and socioeconomic equity in the United States and globally. Dean Matthew has held a number of important positions in the policy world. She served as the Robert Wood Johnson Health Policy Fellow for U.S. Senator Debbie Stabenow, as Senior Advisor in the Office of Civil Rights at the U.S. Environmental Protection Agency, and as a Visiting Fellow for the Congressional Black Caucus Foundation. She currently serves as a non-resident senior scholar in the Center for Health Policy at the Brookings Institution and is a member of the American Law Institute. She also serves on several public health boards, including the CDC's Advisory Committee on Immunization Practices COVID-19 Vaccine Working Group, the American Society of Law, Medicine, and Ethics, and the Scientific Advisory Council of the Foundation for Opioid Response Efforts. A prolific writer, she is the author of the best-selling book, Just Medicine, A Cure for Racial Inequality in American Healthcare, and the newly released book, Just Health, Treating Structural Racism to Heal America, and is the co-author of a casebook on public health law, ethics, and policy. With numerous articles and book chapters to her credit, Dean Matthew is a prolific scholar in health, public health, and civil rights law. Dean Matthews received a BA in economics from Harvard Radcliffe College, a JD from the UVA School of Law, and a PhD in health and behavioral sciences from the University of Colorado, Denver. A visionary and strategic leader, we are thrilled to have you here for our first spring Rothenberg Healthcare Law and Policy Speakers Series. And note that I think we have over 200 participants. I will moderate the Q&A at the end of Dean Matthews' talk, so please feel free to put your questions in the chat or send them directly to me. And with that, I turn it over to Dean Matthew. It's a privilege to have you with us.
Oh, Sarah, it is a privilege to be here. Thank you very much for that very generous introduction. I sometimes want people to record that and send it to my adult kids so that they know that somebody likes me somewhere else in the world. I also want to say what a privilege and an honor it is to be here. The one thing about the Health Law Academy is that it is very supportive and very close-knit. The people who are leading your health law program, Diane Hoffman, your dean, your former dean, Karen Rothenberg, have been mentors and friends and supporters and inspiration for me for my entire career. Now, they're younger than I am, so I don't know how that happened, but I am so grateful for the opportunity to speak to you, and thank you for your interest in my new book, Just Health. Now, I'm going to see if I can show you my slide deck. And it is my hope that you're looking at it, not the presenter view. And if it is, then I will get started talking about this project, Treating Structural Racism to Heal America. I'm going to focus, Sarah, on medical legal partnerships. That's going to be the punchline. So there you have it. Nobody has to listen for the rest if you don't want to. But I have a lot of slides because this is a book that's a combination of my social science background and my legal background, and I have way too much to say. So I'm going to speak at the speed of a New Yorker, not of a responsible, respectable teacher. So please just wave me down if I'm really going too fast, but I have a lot of ground to cover and I'm going to get started. I'm level setting under the assumption that everybody in the audience agrees that health equity is something that we can achieve by eliminating unfairness, unjust differences, so that everyone has a fair and just opportunity to be healthy. I think that if you walk away with absolutely nothing else from this presentation, but you understand that health is a byproduct of justice, then you've got my entire book and my entire presentation. I'm going to make it in 5 parts. I'm going to start with a description of what structural racism is. In order to do that, I'm going to start with a more generic structural inequality, explain that and its relationship to health, and then drill down on defining structural racism and how it affects health. Part 3 will give me an opportunity to tell you what law has to do with it. It's the major contribution of the book, I think. Part 4 is how we change it, and part 5 is the medical legal partnership role, if I may, in conclusion. So this is a meme that everybody has seen, that we are talking in law when we talk about equality, about treating everyone the same. In health, when we talk about reaching equity, we're talking about treating people in a way that they need in order to have the opportunity that is the same as other opportunities. And that necessarily means that we have to make distinctions among people. Unfortunately, the distinctions in our society have gone one way, and I'll talk a little bit about that generically now as I start with part 1. What is structural inequality? It actually operates around the world. If we define inequality as the differences between the wealth and income, the success, the resources of the top quintile and bottom quintile of a society, we can measure that with something the World Bank calls the Gini index. I won't go into it. If you need a tutorial on that, there's some footnotes in the book, but you can see that the differences between the haves and the have-nots among the OECD nations from the period shown on this graph is pretty much the same except for one country, which is ours. The United States has the highest Gini index and therefore the highest degree of inequality. I'm not talking absolute wealth. I'm talking about the differences, the gap between the haves and the have-nots. That has a direct and positive impact on health and social outcomes. This is a graph taken from a study by Wilkerson and Pickard, and they charted the relationship between that Gini index I just showed you in the prior slide, inequality on the bottom x-axis, against an index of health and social outcomes in each of these societies. That index is made up of 10 different components, gaps in disease, death by diseases, including diabetes, heart disease, different forms of cancer, also gaps in educational attainment in a society. And what you see here is a very reliable and predictable positive relationship. In a nutshell, the more unequal a society is, the less healthy it is. What is the most unequal society? Look at the far upper right-hand corner. The highest Gini index also gives you the worst social and health outcomes in any of these OECD countries. That is the lesson of structural inequality. The structures of inequality actually have a direct and adverse impact on health. Now let's turn to structural racism, a version of structural inequality that is specifically described and defined as the same kind of relationship, adverse, between health and inequality by race. Now, race, of course, is a social construct. It's very unique in the United States. So we'll define structural racism for this outset understanding, initial understanding, is the social and economic political system, not ideology, but the system that institutionalizes an ideology. What ideology? White supremacy. The system institutionalizes white supremacy in order to accomplish two things. One, to create hierarchies of value on individuals so that I am inferior to you who are superior, or you are more important than I am. So there is a hierarchy that tells us who is more or less valuable in a system of structural inequality. That's number one. The second thing that it accomplishes is it distributes society's resources, the wealth, the power, the opportunity, all of the resources that society has are distributed along these hierarchies. So structural racism creates hierarchies that define opportunity and privilege in society. So the book starts with a story. In order to make this real, these are my parents. My mom and my dad in this picture were in their late 40s, 47 for my dad, 46 for my mom. My father died 2 years after this picture was taken. Why did he die at 49? Why did my mother die? And I can't tell her age anymore because she died younger than me, but she died younger than me. And if I tell you her age, you'll know my age, but let's just say she died too early. And she died, along with my father, prematurely, I posit, because of structural racism. The inequality that consigned them because of their race, because of how they look, because of their social status in the United States, to low wages, substandard education, residential segregation, violence in our neighborhood of the South Bronx, and all of the inequalities in the social determinants of health that are distributed inequitably by race in a system of structural racism. To finalize the point of the import, the impact, and the influence of structural racism, let me just tell you the story of a plane that you already know. Flight 1549, US Airways, was flown by Captain Sullenberger, Chelsea Sully Sullenberger. It landed on the Hudson River in January. And in January, the Hudson River is not conducive to life. It was freezing. Having hit a gaggle of geese, they had to make an emergency landing. Why do I show you this picture? I want to emphasize that structural inequality, indeed structural racism, has a health impact because of what is pictured on this plane. If we were in the same room, I'd ask you to raise your hand and tell me if you see two groups of people. You would say you do. What are those two groups? The large group in the back of the plane and the smaller group in the front of the plane. The large group in the back of the plane were in coach. They are standing on the wing. They are sinking into the Hudson. And if 155 souls are going to make it, they have the worst chances of all. Those who were in the front of the plane were sitting in first class. They have a lifeboat. They have a life vest. They have little boxes of rations so that if they're out there for any number of days, they don't have to eat each other as soon as the people in the back will have to make those decisions. The point is that where you are on the plane matters, right? Your life chances under the same circumstances, and even more so when those circumstances are adverse, matter depending on where you live. Place matters is all you take from this. And we saw this and are seeing it. Boy, look how outdated this is. We are seeing this in our COVID-19 numbers. Now over 800,000, 900,000 deaths in the United States, and they are distributed by race and ethnicity. This is because where you are on the plane matters. This is why my parents' story is an exemplar of structural racism. Why did this happen? You know the story. I'm going to speed through these slides. It happened because of the places we live. This is the social determinants. Residential inequality. It happened because of the places we work. In New York City, which is the first hotspot for the COVID pandemic, 30% of all bus drivers are people of color. 20% of all food service workers that made sure we had DoorDash are people of color. 25% of those who ride public transportation are people of color. Where they work and how they work mattered to their vulnerability. This is akin to where they were sitting on the plane. Where they went to school determined where they worked and where they lived. And we looked at inequality in New York City just to understand that the reason my parents died early was to make sure I didn't become subject to this educational inequality. My parents worked 4 jobs and at one point 5 between them so that I did not have to go to school in the South Bronx. In order to work 5 jobs, you sleep 5 hours, you sleep 5 hours, you die at 49 a night, 5 hours a night. So where you live, where you work, where you play, even in rural areas, makes a difference. It is the same as saying where you sit on the plane. Now, structural racism, I'm still defining it. I'll finish with this slide. This is a picture of dead fish on a beach. I take this example from a group called the Equal Justice Institute. They have a teaching about racism called the groundwater theory. And it basically says, if I'm walking along the beach and I see one dead fish, I say something's wrong with the fish. If I am walking along the beach and I see that the beach is covered with fish who are dead, I say something is wrong with the ocean. Structural racism is an explanation for what is wrong with the ocean in the United States of America. I diagram it in the book like this. We know from the top of this diagram that interpersonal prejudice, racism, individually, right? Bias individually. Bigots who act individually in their interpersonal relationship are unpleasant, unkind, and in some instances evil. But it must be generalized through the social determinants of health in order to produce a consistently disparate set of health outcomes that look like dead fish on the beach. And the ocean's problem is structural racism. Structural racism, I suggest, is created by law by legally dehumanizing, institutionalizing inequality, and making sure that the laws designed to protect equality are unenforced. Let me say that again. Structural racism is created and maintained. It is the problem in the ocean, if you will, by laws that legalize dehumanization, by laws that legalize inequality, and by ensuring that the laws designed to create equality, to protect equality, go under or unenforced. That's the problem in the ocean. I'm on part 3. What's law got to do with it? Let's talk about legalized inequality, legalized structural racism. I love this quote because, I'll give you a chance to read it. Frederick Douglass captured the pain and agony of being a part of a country that used its most powerful institution, the law, in order to make sure that his body, soul, and spirit were not free. This we see through property laws, insurance laws. This is a powerful picture of selling a woman in slavery by the pound. This is what I mean by legalized dehumanization. This was our system. If you don't know the story of the Zong slave ship, it's another example of legalized dehumanization. This is a case that involved an insurance claim for property, i.e. human beings, who were deliberately destroyed as the slave ship Zong lost its way and lost its provisions. In order to stay alive, they offloaded live human beings and then claimed insurance to recover for it. This is legalized dehumanization. This is the opposite of equal justice under the law. We see it throughout the Jim Crow period, unless you think that the Jim Crow period was just about those voting rights that are being unraveled, by the way, under our current legal regime. Just about sitting in the back of the book, one of the most intriguing pieces of research that I was able to do for this book with the help of an amazing set of students who would look up segregation laws in every one of the 50 states and see how pervasively we used law to discriminate against human beings, whether they were in education, in hospitals, in employment, in penal institutions, and some of my favorites, in circuses and in cemeteries. We had to make sure that our laws segregated people by race even after death. Laws used to make us dehumanized in the distribution of the things that humans need in order to live. Water. Flint is not the only example. It's the one that will recall for you that there are at least 20 cities in the United States with the lead pipe problem that Flint has. Law is used to dehumanize by allowing the exercise of violence under the color of law, even though this individual was convicted. Let me assure you that every single day of every single week of every single year in the United States, others' stories are not told that are equally egregious. And this is what dehumanized law looks like. Dehumanization looks like criminal justice enforcement that looks at the same behavior by those who are white as those who are of color and treats them differently. On the left, you see the marijuana prevalence usage between 2014 and 2019 by Blacks, green bars, and whites, yellow bars, very similar. On the right, you see the difference in arrest rate by Blacks, green bars, by whites, yellow bars. Law is the mechanism of structural racism. Law creates the hierarchies, institutionalizes white supremacy, distributes resources, opportunity, power, health inequitably by race. The good news is that these structures were created and are maintained by law and therefore can be dismantled by law. That's why I wrote the book. I wrote the book to say that we actually can do something about this. We in the Legal Academy have a special responsibility to partner with those in the Medical Academy to do something about this. That is why justice is good for your health. I'm going to end here by just uplifting one of the most poignant statements I've heard about why equality and equal protection are this way forward. And it was by Kimberly Latrice Jones. She's a Black Lives Matter activist. And if you ever get a chance to see her on YouTube make this statement, she says, they are lucky that what Black people are looking for is equality and not revenge. And that is what I am looking for. I'm hoping this book reconceptualizes what equality is, how we get to it, and who's responsible for getting us there. So part 4, who can help us? The reason I think the partnership has to be between those who understand the law and its role in dehumanization and legalizing inequality, and those who are in medicine, in the health field, is because health is the best quantifiable example or expression of legal inequality. It's amazing how powerfully consistent the data that we collected for this book is. So here you're showing the Black-white infant mortality rate gap, the gap, not the absolute number, the gap, right? So let's look first at the bottom blue line, which is Black or African-American infant mortality rates going down over time. We have developments in medicine, we have developments in nutrition, we have developments in education that have decreased the absolute rate of infant mortality among Blacks and African Americans, Blacks from the diaspora of Africa and African Americans who are descendants of slaves. Let's look next at the yellow line or orange line, non-Hispanic whites, same thing. There has been a decrease in the absolute number. Things have gotten better for all of us, and that is to be celebrated. The line that I want you to take as the message from this graph is the top gray line. That line describes the ratio of infant mortality between Blacks and whites. Just take a glance at the 1915 location. The gap, the ratio was 140. And the place for that graph, I'm sorry, the gap was at just over 2 to 1 in 1950. And here we are in 2015, and the gap is 2.5 times for Blacks what the infant mortality rate is for whites. All right, so from 1915 to 2005, the difference between infant mortality for whites and Blacks has gotten worse. Same is true for all-cause mortality. We could do it line by line, but you see the difference here. All-cause mortality, an unchanged Black-white death rate. Now, there's a little section in the book where I do a little experiment doing a regression to try and understand whether the changes in laws during these periods made any difference. And I can make an argument that needs further research, but I can make an argument that immediately following enforcement of the Equal Protection Act during Reconstruction the first and Reconstruction the second, you see a narrowing of the gap in infant mortality and a narrowing of the gap of all-cause death rates between Blacks and whites. From that, I suggest that further research could support a theory that improved laws actually improves our basic health outcomes. But this is just a suggestion. It's one I'd like to follow up after this. But look at the ways in which health has changed the equality conversation. Health was as segregated an institution as churches, as schools, and yet you never saw this scene. You didn't have to see fire hoses or marches and dogs in order to integrate. And it was because law was used by healthcare professionals to desegregate hospitals during the second Reconstruction. I call the civil rights movement era the second Reconstruction, right? If you look at some of the historical literature. I think David Barton Smith has one of the most interesting accounts of desegregation of hospitals in the South. Simpkins v. Cone, I'm sure, is a case that's familiar to all of you. Who brought this case? Dentists, doctors, and patients brought this case in order to desegregate the Moses H. Cone Memorial Hospital in North Carolina. It's a fabulous case. I'd love to spend a lot of time on it, but I don't have the time to spend now. But suffice it to say that two things are relevant. One, after this case, 7,160 hospitals were desegregated. Two, we got the Civil Rights Act of 1965. 64, we would not have had it not been for the fact that this case was in the Fourth Circuit on appeal to the Supreme Court. If you look at the legislative history of the Title VI section of the Civil Rights Act of 1964, you will find that the discussion on the floor was that if we don't pass Title VI, we're going to have to litigate Moses H. Cone Hospital over and over again. What I'm trying to suggest at this point is that the partnership between health professionals, health academics, and legal professionals and legal academics changes civil rights. It was physicians that brought this case, and they created a quiet revolution that changed civil rights access to, again, the second Reconstruction for healthcare, and they did it for other social determinants of health. Let me give you some examples. Unequal access to decent housing is a social determinant of health. This is what the discrimination used to look like. Blatant signs that said, we don't want you in our community. Then later on, I'm going to use my own hometown of the South Bronx. It was redlining. You're familiar with The Color of Law, David Richard Rosenstein's book about redlining and the use of federal law to make sure that we institutionalize segregation. Let me pause here just for a second. Matt Desmond has a book that I think is very important. It makes clear that residential segregation actually had to be invented. And if you do an oral history of some small areas, I did it for Charlottesville, you'll find that that's exactly true. Right after the Civil War, of course, during the time of slavery, there was segregation was complete. But right after the Civil War, during our Reconstruction period, short-lived though it was, people lived where they wanted to live. Reconstruction actually worked. It was because of ordinances such as were passed in the city of Charlottesville by the city of Charlottesville City Council that literally made a 9-paragraph rule that told people where they had to move from and to in order to create a segregated society. Segregation is probably the most efficient way to structurally enforce racism, right? Because once you segregate neighborhoods, you've segregated all the resources that go along with neighborhoods, right? It was because I lived in the South Bronx that my parents took 5 jobs between them so that I wouldn't have to go to school in the South Bronx. And that's what led to their early demise, right? And so segregated housing is a pathway to poor health. It was for my parents, the fatal pathway, right? Because they had to make sure that we got out of the concentrated poverty, the criminal infrastructure and decay. They had to get me social capital so that I could admit to college, so that I could admit to law school. They had to put me in social groups where the behaviors would move me out of the South Bronx and into settings where people were running and hiking and climbing and swimming and skiing to stay healthy, right? As opposed to medicating the pain of living in a neighborhood like I grew up in, right? This is why starting with housing and education seems to me to be the best place that we can put our resources in medical legal partnerships, the best place that we can fight for civil rights that will actually have an outcome on health. The segregation, the substandard quality, this is a very old slide. I wasn't able to find any more recent data. I welcome anybody who can, but it's very telling. When we look at the prevalence of substandard housing, at least through 2001, it is highly racialized, right? Black and Hispanic people have the largest number of severe to moderate physical problems. That's no heating, pest infestation, lead paint, the kinds of things that affect health that are directly, empirically shown to direct health, have the highest concentration in the United States by race. Think dead fish on the beach, right? It is this group of people that have the poor housing. It is this group of people that have, I'm using Boston here, the building code violations concentrated in their neighborhoods. I'm going through these quickly, but what you'll see on the left is a dot map that each dot stands for 120 people of a particular race. Greene in Boston is concentrated in the northern parts of Boston's area, Brookline, Fenway Park, Cambridge, right? Blacks are concentrated in the southern part, Roxbury, Dorchester, right? And if you put that beside where the building code violations for no heat, poor utilities, indoor plumbing being dysfunctional, you find that the red areas are concentrated in the South where Blacks and Latinos live, and the green areas where there are fewer building code violations are concentrated in the North. Would that this were just Boston? It's not. It's Washington, D.C., same pattern. Home ownership that tells us where generational wealth from your housing condition or status will flow is also highly racialized. I'm using just some cities that it was easy to get maps for, right? But again, if we look at affordability of housing as a social determinant of health, if only because if you own your house, you have enough wealth in order to get your children the kind of education that will allow them to get jobs like I had, that you have, right? But also, affordable housing has been shown to be correlated with how much a family will spend on education and food for their children, right? So these are different pathways that not only I'm doing building code violations, again, these are a little bit out of order, I apologize for that. The same thing that you saw in New York, excuse me, in Boston and Washington, D.C., you will see here, the concentration in blue dot neighborhoods that are Black and orange neighborhoods that are Latino, is where building code violations are in New York City, Manhattan, Lower East and Upper West Side, white areas, very few building code violations. I think the point is made. This is a health issue, right? I'm trying by this series of slides to suggest that discrimination, structural racism is a health problem. It's, as our CDC president, Rachel Walensky, said, racism is a public health problem. I'll just add structural racism because of how it's replicated by law. Look at where asthma is most prevalent in the in New York City. It's in the South Bronx where the building code violations are, where the home ownership is lowest, right? If we look at food insecurity and obesity in the South Bronx, it is highest in these dark blue areas. Why? It's highest, that is, respondents on the left who say they don't have enough food, darkest blue, in the South Bronx areas where I grew up, because that is where Black and brown people are concentrated. This is structural racism. Surprise, surprise, that's also where obesity is concentrated, right? If you are food insecure, you are eating poorly toward obesity. This is why when we look at the social determinants of health and we look at that, there's a beautiful map. I know most of the people in the audience here already know it, that tell us that 10% of your determinant of your health is genetic. Another 10% is your access to clinical services, so you get medical care. Fully 30% is health behaviors, right? 40% is social and environmental. I suggest that the 30% that's behavioral is also social and environmental, right? I eat poorly in the South Bronx because I am food insecure. I'll speed through the rest of these. Income is lowest in the South Bronx. Of all zip codes in the United States, my zip code where I grew up was here. This is a social determinant of health. In Boston, same thing, home ownership and rentals concentrated rentals, power very compromised and subordinated in Black and brown neighborhoods as compared to white neighborhoods. Unequal access to decent education, same thing. It used to look like this. We used to tell people they couldn't go to school. Brown versus Board of Education happened. We desegregated schools. Plyler versus Doe said that public education was a right, but then we defunded the schools, right? So the pathway to poor education, to poor health from low education attainment is in this diagram shown from a beautiful study by, I think the first name is Carolyn, but the last name is Hogue, H-A-U-G-E, if I'm not mistaken. Look at the association between high or low educational attainment and your health. It makes a difference. What kind of job you get, your social standing, your social supports, the working conditions, these all affect health. The stress that affects your health behavior, your resources, right? When I am stressed in the dean's office, I close my door and I pull out my golf iron and I swing. If I'm really upset, I'll put on a pair of earmuffs and I'll run down and sit on the steps of the Washington Monument. If anybody on my staff does that, they have to clock out. The difference between my work conditions and their work conditions, the difference between the hazards that I'm exposed to and others are exposed to, my sick leave, my benefits, all of this affects my health outcomes, and it's based entirely on educational attainment. That's why my parents worked to get me out of the South Bronx. I'm going to go much faster. Funding is disparate. If you haven't seen the study that says that students of color, districts that are predominantly occupied by students of color, receive $23 billion with a B less in education funding than students that are districts that are predominantly white. You need to see that study. It's in 2019 by Lauren Camara. These are all structurally enforced racial disparities. Remember what structural racism is, right? It is a system that orders who gets resources by race and ethnicity. Education is a resource. This is how it operates, right? Funding for students of color is disparate. These are just more depressing statistics about how disparate they are. And when that happens, it's not just the funding for the school districts, it's the location. This is a terrible, terrible picture. But I had to include it because it's exemplary of one of the medical legal partnership cases that we did in Colorado, looking at the location of schools in Black and brown neighborhoods. In that case, it was in Denver. Here, this is the South Bronx. But if you look at purple industrial sites where manufacturing and therefore pollution occurs, whether it's noise pollution or air pollution, right, occurs, and then look at the location of those little red flag dots, elementary schools in the South Bronx, they sit right in the middle of a U of purple industrial locations, right? In the South Bronx, schools are next to industrial locations. I could tell you a story. I won't, I'm almost at the end of my slide deck, and we can come back and talk about anything that is of interest to you. I'm just giving you example after example of structural racism, where you land on the plane if you are Black and brown is structurally inferior to where you land on the plane, sit on the plane if you are not a member of a marginalized community. The criminal justice disparities then, I showed you probably the most poignant difference, the marijuana differences in use, prevalence, and race, but also we can look at the crime rate in the South Bronx as compared to the quality of public schools. Why was this the main job, the number one priority of my parents? Because the quality of the schools, those who went to PS 123, which was my middle school, where I would have gone, I started in elementary school in PS 93. Those of my friends who went to PS 123 are either dead, in jail, on drugs. Those are the three options to them. Those of us that got out, and you'll read in the book, those of us that got out, I'm going to do a reunion of them, the Inces, the Greenes. All of our parents are dead, but we all got out because our parents took us away from the public schools in the South Bronx and put us in places where the crime rate was low and the schools were superior, but that doesn't do the job if the disciplinary practices in the school is as disparate as these data show us that they are. The Office of Civil Rights reports that disparities in suspensions and expulsions are highly racialized. I could spend a lot of time on this. I do in the book. The reason I do in the book is because some of these data start in, are you ready? Preschool. 3-year-olds are disparately suspended for like behavior, a Yale study tells us, as compared to Black and when you compare Black and white students. That's a fabulous study, but it shows that this suspension in disparities, expulsions in the disparities in race and expulsions take kids out of school, thereby consigning them to underperformance in school. And if you are in school and you act up, this is data from Connecticut, if you are in school and you're a student of color and you act up, we are seeing disparities in referrals to treatment, right? For example, in autism diagnosis versus incarceration with juvenile detention, highly racialized, highly racialized. This is, again, another example, think fish on the beach, of racial disparities that are structural and systemic. This is just another way to look at the same data of ethnic and racial disparities in school. Who gets suspended? Who gets access to math, science, AP, IB, and college prep courses? The disparities are vast. Again, white students, 81% of them go to schools in the United States which have a full complement of pre-college math, science. 47% of Native Americans go to schools where they have a full complement of math and science and pre-college courses. The correlation between your outcomes as an adult by health and your ability to be educated. This is kindergarten scores, but this is my favorite one of these. Non-Hispanic white males, non-Hispanic Black males, the two top panels, non-Hispanic white females, non-Hispanic Black females, the two bottom panels. You take away 2 lessons from here. One, you get to high school, you live longer, right? The risk of death plummets after you graduate from 12th grade. Plummets, and it plummets for all races. The other findings in this study were fascinating, but you should take away that getting an education helps you live healthier, longer lives. So the extent to which education is systemically racist, access to funding, access to discipline, access to the quality of teachers and the quality of education, it's deadly. It has an effect on life. So let me conclude by saying why I think medical legal partnerships are required. Simpkins v. Cone is probably the most powerful exemplar, but it is my belief that healthcare is the hub of all interventions to equalize access to the social determinants of health. This is for a host of reasons I try to spin out in the book. One, health providers can help us measure the effect of impacts in education, in housing, in jobs, in nutrition, right? They can help us measure it. The other reason is because, remember the march? Remember the case, the Simpkins v. Cone case? Remember the Medical Committee on Civil Rights that was later named the Medical Committee on Health Rights? There is a voice, and I can recall this from when I was working for Senator Stabenow. There is a voice that the medical community has that it's able to leverage, that's like no other voice. If the medical community begins to partner with the legal community to see that health is a civil right, to see that it is utterly impossible to give equal access to civil rights without changing and enforcing our laws, humanizing people under the law, removing legalized enforcement of inequality, such as we saw in Flint, Michigan, and institutionalizing serious enforcement of the civil rights law. That, I believe, is when we'll see change. The book also ends with some examples of this being done by health systems that are interested in seeing their role in being the change to our structural racist system. In housing, there are health systems involved. This is one of my favorite. In food security. If you want to know about this one, this is amazing. Ask me about the Brockton Neighborhood Health Center and their grocery store that they have invested in. San Antonio has a school of medicine that has treated food as a prescription. This is another one, Meals on Wheels, those are familiar, but violence prevention is some of the most intriguing ones to me. Establishing Project Ujima, for example, that is a violence prevention, a mentoring program to treat violence differently as a health issue rather than as a criminal justice issue. Anyway, there are lots of examples of this, but these are on a episodic level, and I'm hoping that the book leads us to a quiet revolution the second time around to recognize that medical rights are civil rights, health rights are civil rights. I use this picture to close on because it's a stand of redwood trees that look as though they are each individual organisms in their own right. I'm not a botanist, I know nothing about trees, but I do know this. Redwood stands are interconnected underground. They stand because they are all dependent upon one another. And I believe that the answer to structural racism is an interdependent effort to make medical rights civil rights in medical legal partnerships. So I'll end there. I hope I left enough time for questions.
Thank you so much, Dean Matthew. That was extremely informative, and I didn't have the heart to send you a message saying we were getting close to your hour because I think it was so fascinating. And I think we're okay staying on for an extra 5 minutes if people have questions. So I think we'll have time for questions. I guess the first question to you, there's been some interest in the chat that I've been monitoring about taking action and sort of engaging in this medical legal partnership approach that you're promoting. So being one myself who teaches a medical legal partnership clinic, I think a lot of if we accept the premise, which I think we do, that these upstream social determinants of health affect health outcomes, a lot of the MLPs that exist work on a much more individual basis, right? We rely on our medical partners to be gatekeepers, to screen for cases. We're adopting the premise that healthcare involves this interdisciplinary approach, and we talk a lot about role. What is the role of each discipline? So if we wanted to sort of utilize your concept of using a medical legal partnership to address structural racism and health disparities and equity on a larger scale, and people want to take action, what are your thoughts or comments on the role that each discipline, law and medicine, would play if we want to move to action steps?
Thanks, Sarah. I want to say medical legal partnerships that are operating, there's about 400 of them in the country right now. They're doing a fabulous job. Because I want to do something in addition to them, I don't want to seem as though I'm being critical. I think you do two things. One, the medical legal partnership model was intended to grow into policy interventions, to look at large scale advocacy on a policy level as a result or as an outgrowth of the individual patient by patient, client by client representation, right? So I think Emily Benfer has probably one of the most intriguing models that she used at University of Chicago at Loyola. That Health Justice Project looked at repeated violations of eviction law, right? And then turned that into policy advocacy all the way up to the United States Senate. Sidney Watson did something similar with respect to Medicaid in St. Louis, but you would be taking on the kinds of policy legal interventions that would affect broadly the populations that you are seeing in your medical legal partnership on an individual basis. The second thing that you might also be doing is looking instead at a individualized intervention for benefits or for making sure you do an appeal for a DACA. I don't even know if you could do that anymore. We did DACA appeals to get one person some relief And it changes a life. Don't get me wrong, it absolutely changes a life. But instead, you might be looking at civil rights issues writ large as health issues. So your medical legal partnership could be about civil rights law. It could be bringing litigation or writing amicus briefs in cases like Simpkins v. Cohn today. It could be writing briefs in cases that are dismantling the Voting Rights Act as a health intervention and generating the research that explains that representation makes a difference in housing affordability, makes a difference in school funding, and therefore is a health intervention as well.
Thank you. We have a couple of questions that came in because the COVID pandemic is obviously on the forefront of everybody's mind. So a couple of questions came in regarding how what you've talked about is present and seen during the current COVID-19 pandemic. One of the questions was about how racism, and I guess we didn't talk today a lot about sort of unconscious racism and implicit bias, but how unconscious racism or implicit bias and or overt discrimination contributed to the health disparities we've seen based on race and ethnicity, during COVID. It's probably a whole other talk, but
it is another talk. But
yeah.
if you remember the diagram, if you think about implicit bias, that was my topic in Just Medicine. I'm going to be a little bit provocative and say, if you remember back to March of 2020, around February, March of 2020, the hotspots were all places of color where there was a disproportionate level of a concentration of people of color. New York, Ninth Ward, Louisiana, Chicago, those were the hotspots. And I will say that I believe that implicitly we were biased to think that that's where that pandemic was going to stay, right? That's where those people were going to be affected. And that changed, or at least slowed, our reaction as a nation. Now, a lot of things changed and slowed our reaction as a nation. But I think at least that implicit bias, right, that saw us as different, them over there overseas, those are the people that are going to have the hard time with this disease. We marshaled our national resources slowly to our peril. And I think that is one of the key ways that this pandemic, there are tons of other ways, but I don't think that is I think that's a moment as well. That's what I would say implicit bias on a sort of a writ large did to harm us all,
Yeah, thank you. The other COVID related question is, what, if any, thoughts do you have about the lawsuits against New York challenging its use of race in their decisions to allocate monoclonal antibodies and other early intervention treatments for COVID patients?
I would love to see a medical legal partnership start to take a position on those, writing briefs. I would love to see us as the medical legal community tell the people who are making those arguments what is actually true about making intentional use. There's a great book called When Affirmative Action Was White, right? When use of race and ethnicity benefits white people, we're all for it, right? And when it doesn't, there are all kinds of reasons to level against it. So I'm thinking if we can start taking these as part of our medical legal partnership cases, we could do some good.
That's a great suggestion. Do you think this case would survive a strict scrutiny test under the Equal Protection Clause of the 14th Amendment? If
enough of us, so now you're going to get into the terrible space of being in my my con law class. One of the things I make clear in constitutional law, and I try to make clear in this book, is that the Equal Protection Clause strict scrutiny standard says what white people in power want it to say right now under the law, because it is status quo enforcing, right? We think of originalism as though it's something that was written in heaven somewhere. Originalism is not what people who were on the ground being affected by the Equal Protection Act thought originally it would do. It's what the white power structure thought it should do. That's where those divisions of equality for political, but not social reasons came from. They didn't come from the people who were looking like me and wondering if the law was going to protect them. If you want to be an originalist, include their original views of what they thought equal protection would look like. I think we should change what the strict scrutiny structure looks like so that, yes, eventually it will survive, because that's, I think, what the original intent of equal protection was. But boy, do I digress.
Thank you. You have lots and lots of comments in the chat, which you should read afterwards, complimenting your amazing presentation, that it should be heard by public health experts and basically everybody who has any power to change anything. So you got resounding applause from everybody. I guess the last question that I have, and then we can probably take one more after that, is if there's any distinction that you've seen in disparities related to physical health versus mental health. We sort of just talked about health outcomes in general, and I don't know if these issues of the impact of racism affect mental or physical health differently, if those things play out differently at all.
I have so much to learn in this area. I wish I had started my research in time to have included more information about the disparities in mental health. They're vast, they're complicated, they're not, I can't apply the same lessons that I've applied in physical health. One of my heroes, Nicole Hannah-Jones, tweeted out one time, "I've never let a book go that I thought was finished." And this book is not finished. One of the glaring omissions of several is that I analyze mental health. I don't know a lot about it, Sarah, is the long way of, that's a long way of saying. I know that the disparities of diagnosis are vast. I also know that the disparities of uptake are vast. The access to mental health treatment is vast. One of the studies that might suggest something important here was done at the University of Virginia, and it was a study on pain and how people perceive Blacks to respond to pain. The perceptions of what the mental responses and the psychological responses are of Black people and white people are vastly different among professionals. But that's a long way around saying I still have a lot to learn on this.
There's a lot there. Thank you very much for that. And again, tons and tons of comments in the chat about how much people are learning from you, and several people sort of motivated to join forces with anybody else who wants to connect in doing some medical legal partnership. So I think this also served to make a lot of connections for people who want to further the work.
That's fun.
So I think it's 5:05. We'll be respectful of people's time. Thank you so much. It was really a privilege to have you, and your contributions are incredible.
Thank you so much for having me. I enjoyed it and was honored to be with you.
Thank you so much, Dayna. And thank all of you for coming. It was a fabulous presentation, really wonderful. And we'll provide you with the chat, I think. I think that might be good because there are a lot of suggestions in here that we might want to send her.
Fabulous. How does she have the energy after being a dean all day to give that talk?